I'm Norm Campbell. I'm a professor emeritus at the University of Calgary. I've spent my career in population prevention and control of hypertension, and it's my great honor to chair this very important session. Hypertension is the leading reversible risk for death in the world, and indeed in Canada as well. It's also the most expensive single diagnostic entity for provinces. The global best practices has a cornerstone, and that cornerstone is really interdisciplinary care, which is underutilized in Canada. One of the best opportunities to improve our healthcare system is to optimize the role of pharmacists and pharmacy in chronic disease management and in hypertension. So this session is very important to the effort to control hypertension. The barriers to pharmacists having a bigger role are really artificial. Governments complain about the healthcare system, but have introduced regulations that prevent the optimization of pharmacists playing a bigger role in hypertension control. The other issue is turf protection by physicians who are currently overwhelmed and can't manage disease in the country, but somehow want to continue to protect that. So we really need to move more to patient-centered care with an important role for pharmacists. Today we have three different sessions. One research on screening for hypertension in pharmacies. One from Dr. Tsuyuki on the evidence that pharmacists can enhance hypertension control. And then finally, a vision for the role of pharmacists in hypertension management. I'll introduce our speakers. Dr. Stephanie Gysel, who's a practicing community pharmacist and owns a pharmacy in Calgary. She's a postdoc fellow at the University of Alberta Faculty of Medicine and Dentistry. She co-chairs Canada's Research and Evaluation Committee and is quite passionate about the role of pharmacists. Dr. Tiffany Lee is an assistant professor at Memorial University School of Pharmacy and works there in an anticoagulation clinic. Her research is focused on strengthening community-based health services using applied research methods. Dr. Ross Tsuyuki, I can't say enough about. Dr. Tsuyuki is the past president of Hypertension Canada and has really transformed that organization and positioned it to play a much more important role in the prevention and control of hypertension. And he's editor and chief of the Canadian Pharmacists Journal. Dr. Faisal is a licensed pharmacist who has extensive experience in various different pharmacy settings. She's the director of professional affairs at the Canadian Pharmacists Association. She has a PhD in pharmacy from the University of Waterloo and a special certificate in geriatric pharmacy. Those are our speakers, and so maybe we can kick off the session with screening for hypertension in May Measurement Month. Dr. Gysel and Lee.
Thank you, Dr. Campbell, and hello, everyone. Thank you for joining us today. As mentioned, my name is Tiffany Lee, and I'm an assistant professor at the School of Pharmacy at Memorial University. Myself and Dr. Stephanie Gysel are really delighted to have this opportunity to talk about pharmacy-based screening for hypertension and to share some of our research on the topic today. Before we begin, I'd just like to take a moment to also acknowledge the hard work and dedication of our other research team members, including Dr. Tsuyuki, who you will hear a little bit about later on. And Dr. Tsuyuki, of course, is really the driving force behind much of the work we will present today. I also want to make a shout out to my colleagues here at Memorial University, Dr. Stephanie Young and Dr. Stephen Coombs, as well as a number of undergraduate and graduate students who are part of our local research team here in Newfoundland and Labrador. Next slide, please, Anna. Okay. In terms of disclosures, both Dr. Gysel and I have received some research funding from the not-for-profit and for-profit sectors. These relationships are noted on your screen here. We also undertake some advocacy work, as was mentioned by Dr. Campbell, with Stephanie co-chairing the Hypertension Canada Research and Evaluation Committee, and myself serving as a Zone 1 Director for the Pharmacist Association of Newfoundland and Labrador. Next slide. So the research we will discuss today focuses on pharmacy-based screening for hypertension. Screening for hypertension, of course, is so very important. It's the first step in the detection, treatment, and control cycle. We know that community-based opportunistic and targeted screening programs have been identified by groups like the World Health Organization, Hypertension Canada, the Heart and Stroke Foundation, and so on, as really essential measures to reduce the prevalence of hypertension worldwide. In fact, one of the global targets set by the WHO is to reduce the prevalence of hypertension by 33% by the year 2030, so not that far away, really. So many organizations, are concerned about the growing prevalence of hypertension unawareness. And so what I mean by this is the fact that more than really 40% of adults with hypertension are unaware they have the condition. So their blood pressure is high, but they don't know that it's high. And we are seeing this phenomenon occur more commonly in young Canadians. If you look at the Canadian Health Measures Survey, individuals between the ages of 20 and 39, we often see hypertension unawareness in that group. And so because of these things, of course, screening guidelines have been extended in more recent years to include all adults age 18 years of age and older. So you'll see that on the slide there. For those with a diagnosis of hypertension, blood pressure monitoring and follow-up should take place every 1 to 2 months for individuals who've not reached their target blood pressure, or every 3 to 6 months for those whose blood pressure is well controlled. And so this is quite a big ask for the blood pressure screening to happen so regularly in our communities, towns, and cities. And so we feel that pharmacists and pharmacy teams can play an important role in screening and monitoring for high blood pressure. And we know that Canadians visit their pharmacies quite frequently and can speak with the pharmacist generally without, having to make an appointment. Hypertension Canada certainly recognizes the value of engaging pharmacy teams in hypertension surveillance, and they've been an important organizational partner for the research that we will discuss today. Next slide, please. So back in the fall of 2021, in the year following the start of the COVID-19 pandemic, in the province of Newfoundland and Labrador, with the help of Hypertension Canada and Dr. Tsuyuki, we began working to engage community pharmacy teams in the province in blood pressure screening. And this work really came as the result of new research literature at the time, which highlighted a significant decline in office-based blood pressure measurement and the detection, treatment, and control of hypertension as a result of the COVID-19 pandemic protections that were in place at that time. So our goal with this project was really twofold. Of course, we wanted to gain some insight into the epidemiology of elevated blood pressure, but we also wanted to raise awareness about the importance of blood pressure measurement and to get as many people out as possible to get their blood pressure measured. So we launched the project in May of 2022 and held a just one day, a screening blitz on May 17th as part of World Hypertension Day that year. So to get people out and to take part in the project, we engaged in province-wide promotion of the project. We had paid radio advertising, paid social media advertising. Dr. Tsuyuki actually came to Newfoundland and did some interviews with local reporters, and he was featured on the evening news, actually. So, we were very pleased to have 32 pharmacies from across the island portion of the province take part in the project that year. And many sites had students on rotation at the time. And so we were able to also engage them in the project. We offered training for pharmacists and students at all sites. We did virtual site visits with the students. and provided clinic-grade automated office devices and other supplies to each pharmacy. So the blood pressure measurement devices that we supplied were the BP, or sorry, the Watch BP office, and they were able to collect 3 blood pressure measurements from participants and follow the recommended guidelines by Hypertension Canada for blood pressure measurement. So during this one-day event, we were able to screen nearly 500 patients and members of the general public. So just in one day, we were able to get that many people out to get their blood pressure measured. And we enrolled 460 participants in that study. Elevated blood pressure, absolutely a common finding in our study and above Canadian statistics. So you'll see on the slide there in the center of the schematic, the proportion of participants with elevated blood pressure was actually 27%. So that's higher than the Canadian average. And this has been reported, in research many years ago as well, that Newfoundland and Labrador tends to have higher blood pressure than the rest of Canada. So if we look more closely then at the participants with known hypertension, so that's the left side of the schematic on your screen, 36% of those who had hypertension, who told us they had hypertension when they enrolled in the project, so 36% of those had elevated blood pressure, so they weren't meeting their blood pressure targets. And then if you look at the right side of your screen, so those individuals indicated that they did not have a history of hypertension. 20% of those actually had elevated blood pressure. And in fact, 3 of the individuals in that group met the criteria for hypertensive urgency. So they either had a systolic blood pressure greater than 180 or diastolic greater than 110. And so they would have been sent off for urgent care. And, when we performed our analysis, we did see that increasing age, male sex, and diabetes were statistically significant predictors of elevated blood pressure in the multivariate regression model. And in fact, individuals with diabetes in our study were 3.5 times more likely to have elevated blood pressure than those without diabetes. So that really tells us that, we really need to do a better job of helping our patients with diabetes reach their blood pressure targets. And, that's a key to ensuring that we reduce their cardiovascular risk and so on. Next slide. Oh, I should note actually, if you're interested in learning more about that research, I did include the citation. It's published in CJC Open. So if you're interested in reading more about that project, you can take a look at that publication. And I should also note that this project was funded in part by a unrestricted grant from Shoppers Drug Mart, as well as funding held by myself at Memorial University and funding held by Dr. Tsuyuki at the University of Alberta. Thanks, Anna. Sorry about that. You can move on to the next slide now. So beyond 2022, we looked at the opportunity to engage with the Global May Measurement Month organization. And this was really led by Dr. Tsuyuki and Hypertension Canada. And so May Measurement Month is an annual global screening and awareness campaign. It was launched in 2017 by the International Society of Hypertension. And since that time, more than 100 countries have taken part. And so in 2023 and 2024, and Dr. Gysel will tell you a little bit more about this in a moment, we expanded the community pharmacy engagement in blood pressure screening to take part in May Measurement Month. So May Measurement Month really is a misnomer. It starts in May, so it begins May 1st and runs until July 31st of each year. When it originally started back in 2017, it was restricted to May, but because of the COVID-19 pandemic and the strain on healthcare professionals and clinics, they did extend it, the data collection for this campaign until the end of July. Next slide. And so the goals of the May Measurement Month campaign really are to highlight the importance of annual blood pressure measurement, to raise awareness about the dangers associated with elevated blood pressure and hypertension. And the May Measurement Month organization also take steps to advocate and motivate governments to improve blood pressure screening facilities and to reduce the global burden of disease. So prior to 2023, some Canadian health professionals had taken part in the May Measurement Month campaign. However, it had not been completed in Canadian community pharmacies. And so that's when our team, under sort of the direction of, or with assistance by Hypertension Canada, when we really started to get pharmacies involved in May Measurement Month. So with that, what I'll do now is turn it over to Dr. Gysel to tell you a little bit more about our research related to May Measurement Month in 2023 and beyond. So next slide, and Dr. Gysel, over to you.
You need to unmute.
Man, I thought I would do that. All right. Sorry, guys. So thanks, Tiffany. So in 2023, we conducted a cross-sectional study of adults aged 18 years and older at select pharmacies across Alberta, BC, and Newfoundland. All pharmacies followed the common May Measurement Month protocol, and participating pharmacy personnel were required to participate in mandatory training, including a virtual short course on the proper technique for blood pressure management. There were no exclusion criteria, and participants did not need to be a patient of the pharmacy research site to take part in the study. We specifically avoided the recruitment of patients with hypertension from the pharmacy itself, but rather used the pharmacy as a convenient screening location to get a more representative population sample. Data collected was very simple and included basic demographic information, medical history, use of antihypertensives, and lifestyle information. Pharmacy personnel completed 3 blood pressure readings taken at 1-minute intervals, and our primary outcome was elevated blood pressure, which we defined as blood pressure more than 140/90 or more than 130/80 for individuals with diabetes. The mean of the second and third readings were used to estimate the patient's blood pressure. So participants with elevated blood pressure were provided with a written dietary and lifestyle advice along with their blood pressure record. Pharmacist intervention was not a part of this protocol. However, pharmacists provided advice on the management and follow-up to participants based on provincial scope of practice and the participants' mean blood pressure level. So overall, a total of 736 participants took part in the project. 66% of participants were female, and the average age was 52 years. Overall, more than 20% of participants had elevated blood pressure, which is in line with the Canadian statistics. But again, if we broke that down to Dr. Lee's area, Newfoundland, theirs was definitely higher than the Canadian estimates. In other subgroups, participants who had known hypertension had elevated blood pressure above their target, and that was 35.1% of individuals. That's on the top, or the left-hand side of the diagram there. 13% of participants with no known history of hypertension had elevated blood pressure. 51% of participants with diabetes had elevated blood pressure above their target. And 20% of female participants had elevated blood pressure that they were previously unaware of. Next slide, please. So after completion of the first phase of the study, we asked pharmacy personnel who participated in Alberta and BC about the acceptability of this initiative. We had 18 out of 40 pharmacy personnel participate in this questionnaire, and we had emailed them a questionnaire that contained 30 questions in total pertaining to pharmacy personnel demographics and experience, the theoretical framework of acceptability constructs, personal views on compensation for blood pressure screening, and barriers and facilitators that occurred during this project. So overall, pharmacy personnel stated that hypertension screening had a positive influence on their professional satisfaction, that they felt confident in measuring blood pressure and were comfortable reviewing blood pressure results with patients. Pharmacy personnel felt that pharmacy-based screening would help to identify patients who had undiagnosed hypertension, and that pharmacies would like to continue to screen patients. 56% did not feel that screening was a burden on their workload, and 69% agreed that they were adequately staffed for this initiative. Next slide, Anna, please. At the end of the questionnaire, participants were asked, what in your own words do you think is the value of providing blood pressure screening clinics to your patients? Personnel stated it helped to promote the role of the pharmacist in blood pressure screening, increased access to care, and improved patient health literacy. Next slide, Anna. So this initiative allowed us to gain valuable insights as to the best practices to engage in blood pressure screening. So for this to work, all pharmacy team members should be involved. This is not solely a task for pharmacists to complete. As a practicing pharmacist, I encourage pharmacies to leverage their pharmacy technicians, assistants, and students to complete the consenting process to be part of the study, as well as actually doing the blood pressure measurement. The pharmacist role was primarily to discuss the results with the patients and to discuss next steps for management. Workflow planning is essential. So work as a team to identify when to screen patients and which team members have which role. Discuss with your team if clinic days or drop-in screening would work better at your practice. Suggestions are to incorporate screening after prescription drop-off while a patient waits for their prescription to be ready, as an added service during a medication review, and when assessing the appropriateness of a prescription extension or to monitor ongoing therapy. Screening days were largely successful with the use of pharmacy students over the summer. A lot of pharmacies felt that having true screening days, they just did not have the staff for that. So leveraging pharmacy students is a very big part. In addition, best practices to complete this virtual course that we have listed here on blood pressure measurement. I know I personally identified a few things that I was doing incorrectly when doing the course. So it is a very, very good course to do. It's always best to use a Hypertension Canada recommended device at your pharmacy. They are listed on the Hypertension Canada website. And ensure that you do have multiple cuff sizes. Best practice is also an office grade monitor, but we understand that these are costly for a lot of pharmacies. So doing the best that you can with what you have available. So identifying individuals with elevated blood pressure is the starting point for better blood pressure measurement. Community pharmacy personnel are well positioned to provide blood pressure screening and indicated acceptability of this initiative, which we plan to scale up for the next few years. We did do a smaller study in 2024, but have much bigger plans for 2025. And we are also hopeful that one day community pharmacies will be reimbursed for this very valuable service. Anna, I will leave it to you for the next speaker.
Great. Thanks very much. I've been asked to talk about the evidence for pharmacists in the diagnosis, treatment, and control of hypertension. Next slide. So here are my disclosures. Next slide. All right, so let's jump right into it. So a lot of you would probably have heard me present about this previously, but I felt that I needed to. This was the REACTION study, which was the first randomized controlled trial of pharmacist-independent prescribing in hypertension. So the objective was to evaluate the effect of pharmacist prescribing on systolic blood pressure reduction in patients with poorly controlled hypertension. It was designed as a per-patient randomized controlled trial conducted in community pharmacies in Alberta. 248 patients were enrolled who had blood pressure above target, so that is over 140/90 or 130/80 if they had diabetes. And these were screened and recruited by their pharmacist. Next slide, please. So it was a per patient randomization to intervention or control. And so this requires a little bit of explanation. So the intervention is what you would expect. It was pharmacist assessment of blood pressure and cardiovascular risk. They took over the prescribing of the antihypertensive medications, did laboratory testing as necessary, depending on the drugs patients were on, patient education and follow-up. And basically what we did is we taught them to the Hypertension Canada guidelines. If they were randomized to the control group, our ethics actually made us make it an active control group. So what we used as the control was actually the intervention in all the previous studies. So it was a usual pharmacist and physician care, but what it meant was you still had to do an assessment of their blood pressure, written educational materials, which were identical to that in the intervention group, because it was felt that we still had to do something because by definition, to be enrolled in the study, you had to have blood pressure above target. We wrote down the blood pressure values on a wallet card, gave it to the patient, and then referred them to see their physician. So this is how, in the old days, this was the intervention. So just so that you know that, because it's not that we could not use a placebo intervention. In both cases, the patient's physician was notified because that's best practice, and blood pressure results were shared in both groups. Next slide. So here are the demographics. You can see that the average age was 64. About half of them were male. You can see the BMIs were fairly elevated, around 32. About 40-something% had diabetes. And the baseline blood pressures you can see there are about 150/80-something or so. Interestingly, about 80% were already on antihypertensive therapy and an average of 1.7 drugs. So clearly that wasn't enough, but that was where we started from. Next slide, please. So here are the results. The gray bar is the usual care group, and the blue bar is the pharmacist enhanced care, including prescribing group. And so this is the change in blood pressure from time 0 when they were enrolled in the study to the end of 6 months. And so you can see, actually in the control group, there was a 12 mm reduction in systolic blood pressure. So 12 over about 5 reduction. So a pretty decent reduction, actually. But there was a greater reduction if the pharmacist did the prescribing, and that was 18.3 mm of mercury over around 8 mm of mercury. And so that difference was 6.6 over 3.2. The adjusted odds of achieving the target blood pressure was about 2.3 times higher in favor of the pharmacist prescribing group. Okay, next slide. So after we published this, my colleague and former dean at the Memorial University School of Pharmacy, Carlo Mara, had approached me and said, you know, that was really cool, but I wonder if it would save any money. And so this sub-study, which was done sort of after the fact, was actually funded by the Canadian Pharmacists Association. And so what we did is we did an economic model around the results from reaction. And we said, well, and this is my simplistic non-health economist view of this. If you were to reduce the blood pressure, 18.3 millimeters of systolic blood pressure reduction, there'd be some benefits from that. And you know, you can calculate from the epidemiology how many strokes you would avoid, how many myocardial infarctions you would avoid, and how much reduction in end-stage kidney disease there would be. So there would be some cost savings that would occur, not right away, but it would occur. But then there'd be costs to roll out a program like this. And so you'd have to cost out the training of pharmacists. And we just arbitrarily said, it's about $1,000. So we said, okay, we added $1,000 in here, and you would subtract that off the benefits, right? We said that pharmacists should be paid for this. So we didn't know where to start. So basically we took the fee schedule for a family physician and said, well, it should be around the same. So we used those payments, subtracted those off. And then we even said, it's pretty likely that the pharmacist would be more aggressive using more drugs for hypertension. So we arbitrarily said about $30 per month more for drug costs. Okay. And so basically you take the benefits, you subtract off the costs of running a program like that, and that's the cost effectiveness. And then we said, well, what would happen if we were to scale this up outside of Alberta, where 50% of the population of Canada with elevated blood pressure, with uncontrolled blood pressure, were to see their pharmacist instead of usual care? Next slide, please. So as all of you know, when you're evaluating something new, the cost could be higher or lower. Usually they're higher. And the outcomes could be worse or they could be better. And so we have these sort of four quadrants. So if the costs are higher and the outcome is worse, well, that's called a no-brainer. You wouldn't do it, right? But most things fall in that upper right-hand quadrant where the cost is higher and the outcomes are better. But in the case of pharmacist managed hypertension, the outcomes are better and the costs are lower, even after you take into account the costs of running a service and paying pharmacists for that. And so essentially, if we were to apply this to just half of the Canadian population with uncontrolled hypertension over a time horizon of 30 years, you would prevent about 500,000 cardiovascular events. You would have about 1 million life years gained, and the net cost savings after paying pharmacists would be $15.7 billion. So this is what the economists call economically dominant. So it's what I would call kind of a no-brainer that very few things in healthcare actually save money. This is one of them. Next slide. So obviously, I presented to you the prescribing stuff because I knew that you were interested in it. But if you step back, there are probably more trials of pharmacist care in hypertension than almost anything else, including drugs. So I got a chance to work with a group out of Switzerland, and they're doing some big systematic reviews. And this is completely unreadable because there's so many trials, but how many things do you know where there's 93 randomized controlled trials involving 32,000 subjects? Now, most of this doesn't include prescribing. It's mostly the sort of old style education, feedback, and reminders and recommendations to a physician. But you can see a very clear reduction in blood pressure, 5.4 over 2.5. And I guess the takeaway for me is that, wow, this is how many, there's so many RCTs. This is now what I've referenced here is the abstract where we presented it at the World Congress of Pharmacy. It's now being reviewed for publication. And since then, we've updated it. So there are now 95 randomized controlled trials, now going for an even 100. So all this to say that there's a huge amount of evidence for pharmacists in hypertension. There's absolutely no question. But I do want to talk actually about one more systematic review. Next slide, please. So I was contacted in the spring about this one. So this is a group of public health investigators from New Orleans, Tulane University, I believe it is. And they came up with the idea that, hypertension control is really poor in the States, even, much worse. And they need to do something, but you need to decide where to put your efforts. And so they asked the question, which healthcare professional is the best in reducing blood pressure, because that's who you should invest in. And so this had already been reviewed, and the editors of Circulation, Cardiovascular Quality and Outcomes asked if I would write an editorial on this. So I got a chance to review it before it was published. Next slide. So this is a little complicated to read, but each of these panels represents a group of healthcare professionals or individuals. So A is pharmacists. So they took studies where it compared different approaches using different healthcare professionals. So A is pharmacists, B is community health workers. Panel C on the right-hand side at the top is health educators. Panel D is multiple healthcare professionals together. Panel E is nurses, and panel F is physicians. And so what you can see, because this is most of you are pharmacists, I'll point out that the greatest effect was with pharmacists, and the least effect was with physicians. That's not to say that these other approaches are invalid. They are all valid, and we need everyone doing this. But the approach that was taken by the authors is we want to invest in where the biggest bang for the buck is. And their conclusion was pharmacists. Next slide, please. And so this is a quote from their conclusions, which you can read. And then I had the opportunity to write an editorial, which was basically saying, yeah, well, we kind of already know that. And it's not the evidence that's the barrier. There's other barriers. So that was kind of fun to be able to comment on. So that was just published in June of this year. Last thing I'm going to talk about is, next slide, please, is so I want to just, as past president of Hypertension Canada, I want to plug a couple of things that Hypertension Canada is doing. So you may or may not know that we have a professional certification program. It was originally designed for family physicians and pharmacists, and we're expanding it to nurses now as well. It was based on the Hypertension Canada guidelines, and we had this very unique opportunity because we released it. It was ready to go right at the beginning of the pandemic, which is a terrible time to launch anything, but that's when it was ready. And so we were able to test it, though, in a randomized controlled trial, which almost never happens. But because we owned the program, we were able to dole it out in a randomized fashion. And bottom line is, we evaluated not the pharmacists exactly themselves, but when a pharmacist has taken and been certified in hypertension management, their patients showed a 5 millimeter greater reduction in their blood pressure when their pharmacist was certified in hypertension management. So that is kind of, you don't usually get to evaluate these kind of things in such a downstream fashion. So what you see on the left is the Hypertension Canada certification in hypertension management designation, that certificate that you get after taking that course. Next slide, please. So a bunch of things, just to list them off. The certification program I just talked about. We have done guidelines for pharmacists for the last 10 sets of Hypertension Canada guidelines, and they're published in the Canadian Pharmacist Journal. We are also heading towards some new primary care guidelines, and we have pharmacists front and center involved in the development of those. I will give you a preview of that in the next slide. The new blood pressure screening program and May Measurement Month is being conducted in pharmacies, as you've just heard from Doctors Gysel and Lee. And so we're ramping up to do that on a much wider scale in 2025. The Hypertension Canada website has a lot of patient-facing materials that you can use for your patients. We have the device recommendation program, which tells you which devices are validated. We have a good group that goes through all of those. Particularly important when you're talking about recommending a home blood pressure monitor for a patient. You want them to have an accurate device, and so they're all listed there. You may also want to know that we're gearing up our advocacy to advocate for pharmacists prescribing for hypertension. You can see the article on the left that we wrote a couple of years ago about pharmacists prescribing for hypertension. We're also gearing up advocacy for remuneration for screening and management of hypertension as well, because that is the starting point, as Dr. Gysel said. Measurement is the start of better blood pressure management. Next slide, please. I'm going to end off with this, with not enough time to talk about it, but these are the new primary care guidelines that will be coming out in 2025. They are not finalized yet. We are in the consultation phase, but it's a very much simplified diagnostic algorithm. You can see on the left, basically, pretty simple. 130/80 is going to be the new number. You'll be interested in the treatment algorithm. And so the treatment algorithm is very much simplified. And we're following the spirit of the HEARTS program, and we're actually stating what drugs to use. And so you can see that step 1 is going to be a half tablet of telmisartan hydrochlorothiazide, 80/25. So 40 and 12.5 is going to be recommended as a starting point for everyone. If that doesn't work, then you go to a full tablet. We are also advocating for better combination products. We would actually prefer telmisartan and chlorthalidone or indapamide. And so we've actually issued a challenge to the generic drug industry to start making these. And simultaneously, I believe it was last week, we also sent out stuff to the provincial drug bodies to tell them that this is what we're going to do, and you need to cover them, cover these products as well. A lot of them are already covered, but there will be new products like telmisartan and chlorthalidone that we will need to make sure are covered. So my last word to you is that we are under consultation for this. So it is on our website. You can scan that QR code. You can review this, and we're gathering comments until the end of the month. And then that will become the new primary care guidelines. So we're very specifically asking everyone involved in primary care to provide their feedback on this for these new primary, and that will become our new primary care guidelines. So I'll stop there. Thanks very much. I'm going to turn it over to Dr. Faisal.
Thank you so much. Thank you, Hypertension Canada, for the invitation. And thank you so much, Ross, Stephanie, and Tiffany, for showing us the research about evidence on how pharmacists can detect people who are outside the current healthcare system specific to hypertension, and how we can enhance the hypertension treatment and control. Next slide, please. So I want to complement it with another aspect. Why are we talking about pharmacists? I don't think it's a new statistics. We all have heard that more than 6 million Canadians don't have a regular family doctor. We are highly accessible healthcare professional. About 95 to 96% of Canadians live within 5 kilometers of a pharmacy. We are often available without an appointment. I think that makes it easier for patients to seek advice. Patients typically visit their community pharmacy more often than their primary care physician. It's about 6 to 8 times. This frequent interaction allows pharmacists to do all those activities that Stephanie, Tiffany, and Ross has mentioned, whether it comes to monitoring the blood pressure, providing ongoing education, reinforcing the importance of medication adherence. We are the medication expert. We have the extensive knowledge of medications. We can also manage complex hypertensive regimen, and being in the community make pharmacists uniquely situated to help manage hypertension effectively. And as you just heard from my previous presenters, there is a lot of evidence for that. Next slide, please. So chronic disease management and preventive care are essential for maintaining long-term health. And effective chronic disease management involves regular monitoring, whether it's the vital signs and symptoms, ensuring the adherence, or supporting patients with making lifestyle modifications. Pharmacists play a crucial role in hypertension management, both through traditional responsibilities and also the emerging roles that we are seeing. Traditionally, pharmacists have been involved in dispensing medications, providing education, ensuring that patients adhere to their medication regimens, and providing lifestyle modification information, whether it's diet, smoking cessation, or exercise. We also monitor patients for adverse drug reactions, for interactions with other medications. Now, emerging roles for pharmacists include a broader role in chronic disease management, where pharmacists can not only collaborate with their healthcare providers, but they can also help support their patients. And we have seen that given the expanded scope in various jurisdictions of our country, pharmacists are getting involved in supporting patients with managing these chronic conditions, whether it is through independent prescribing in Alberta or through primary care clinics. Some provinces, pharmacists are initiating and adjusting medications, taking a more proactive approach to manage chronic diseases, including hypertension. Many pharmacies have are offering screening services now, also for risk factors, right? So if you have a patient who you feel like have certain risk factors that you can identify and can support that patient, this expanded role helps improve blood pressure control and overall patient outcomes. Next slide, please. So I'm going to start from the beginning, because hypertension detection and screening is the starting point, which play a critical role in preventing serious health complications, whether it's heart attack, whether it's a stroke, whether it's a chronic disease. Early detection through blood pressure monitoring allows for timely intervention, which can significantly reduce the risk for these adverse outcomes. Hypertension is one of those conditions that may not always be obvious. Dr. Lee mentioned in her presentation that about 40% of people are not even aware that they have hypertension. Now, screening those people helps identify as individuals who have a high blood pressure, who may not show any symptoms, and enable the early treatment and lifestyle modification to manage the condition effectively. The role of pharmacist as an educator is one that needs to be highlighted here. We can support or empower our patients to actively participate in their health and well-being through regular touch points. We are integral to this process. We can conduct blood pressure checks during routine visits. We can educate patients on the importance of their regular blood pressure monitoring and explain what constitutes a healthy blood pressure range. If high blood pressure is detected, depending on which jurisdiction we are practicing, we can refer patients for further evaluation, or like I said, in some regions where we can start medication, adjust medications through independent prescribing authority or under collaborative practice agreement. These are the things that can really make a patient's journey in chronic disease management smoother and easier. Next slide, please. Now, we are just talking about how Ross just mentioned about the trial, the randomized controlled trial about pharmacists additional prescribing in Alberta and how they can actually start a medication. Now, in other provinces, pharmacists sometimes have to be in a collaborative practice setting, or they are working in a team where they can actually work with their primary care provider and support patients. In some settings, pharmacists can alter the prescriptions, they can change the dose, they can discontinue the therapy. A role that we all have been playing in the hypertension management by ensuring that medications are used safely and effectively. Medication reviews are very important, where we do try to help our patients, support them through having the optimizing their current treatment regimens and identifying and resolving anything that is related to their drug interaction, monitoring their side effects, or recommended alternative. So whether it's one of those actions that pharmacists are doing, pharmacists are highly involved in chronic disease management and doing the medication optimization for their patients. Next slide, please. I want to just spend a couple of seconds talking about adherence. Medication adherence play a significant role in the management of chronic disease. More than half of chronic disease patients don't take their medications the way they are prescribed. And in some studies, it has been reported up to 80% based on type of disease and patient population. Now, non-adherence can lead to uncontrolled blood pressure, increase the risk of serious health conditions, cardiovascular disease, including heart attack, strokes, chronic kidney disease, and even premature death. And we are all aware that there are a lot of factors that can contribute to this non-adherence. Lack of symptoms is one of them. So that's where the screening of the blood pressure by pharmacists can really play an important role, where you can actually provide support to your patients by monitoring their blood pressure and connecting that with the adherence. Pharmacists can play a crucial role by not only educating on the importance of taking the medication correctly or addressing the concerns about side effects, but we can actually monitor the blood pressure and then offering the follow-up consultations to resolve any issues. We often offer our patients tools such as pill boxes, mobile health apps to help patients remember their medications, and can work very closely with their healthcare providers to ensure the coordinated care. Next slide, please. Now I want to take a few minutes to talk about the vision for the expanded role of pharmacists in hypertension management. So let's see where we could start. We know that a lot of community pharmacies have a blood pressure monitor, and we often see patients checking their blood pressures. When patients drop off a new prescription for hypertension or pick up a refill, ask them if they have checked their blood pressure regularly. If not, educate them on the importance of regular blood pressure check. Explain them what the normal range is and when they should seek medical attention. If you see someone presenting with risk factors, with heart disease, monitoring their blood pressure can actually prevent significant event for them, including a heart attack or a stroke. And if a person reports consistently high blood pressure reading, the next steps could vary based on the jurisdiction where you practice. Another important thing that I want to highlight over here is that patients often want to purchase a blood pressure monitor. There is a power in having valuable information at your fingertips. And just like blood glucose monitoring that we all have been doing for a long time, and we feel like it's really important for us to do when we see a patient presenting with a diabetes prescription, blood pressure monitoring can be made accessible to patients. It can be very interesting exercise to monitor the blood pressure at various points of the day. So ask the patient, when are you checking your blood pressure first thing in the morning? Does it change after you take a big cup of coffee? We are the primary source for them when it comes to choosing a blood pressure device, how to use it, and how to monitor their blood pressure. Remember, prevention is better than cure. And as Stephanie mentioned, we can always lean on our pharmacy technician colleagues, on our pharmacy students who are in the pharmacy with us. We can also use their support to building our capacity to support our patients with device selection. This is a technical role, and when possible, we can actually leverage the training and knowledge of other people who are in our pharmacies to support our patient. Taking a proactive measure to prevent disease is more effective than waiting to treat it after it occurs. For blood pressure, for patients who are diagnosed with blood pressure, knowing how to monitor blood pressure at home and when to contact a healthcare provider can actually change their life, can actually change the therapy, is very crucial. We are in an ideal position, just like I said, that patients see us 5 to 8 times more frequently than the primary care physician, which allows us to support our patients with their hypertension management more effectively. Next slide, please. But in order to have all these things, what needs to happen for our optimal involvement as a pharmacist? I think the policy and regulatory changes regarding expanding the pharmacist scope for prescribing rights, as well as the remuneration of these services, is very crucial. Pharmacists can support and can also reduce the burden on our overwhelmed healthcare system. Just imagine the impact a pharmacist could help their patients without waiting for a very busy physician who is already overworked. Therefore, we are avoiding the delays in the care. We have been optimizing medication for ages, but it is time for us to provide even more support to our patients. So we do need to get ourselves educated. We do need to upgrade our knowledge and expertise to support our patients. Another important challenge that community pharmacies often face is not having the access of electronic medical record. They lack the comprehensive patient information, also their ability to share their assessment or intervention with other healthcare provider, which is very critical. And without having that access, we have a limited capacity to monitor patient outcome and adjustment treatments effectively. So advocating for access to public health data and EMR is very crucial, which will not only enhance patient safety, improve patient care coordination, streamline the workflows, but also it will provide us with essential clinical decision support. Last but not least, technology is everywhere. So we need to have access to tools for remote monitoring so we can actually support our patients in a timely manner. Next slide, please. So this is just a hypertension certification course that Ross also mentioned. If you want to upgrade your knowledge, maybe this is where we have to start. Next slide, please. A couple of resources about the list of recommended blood pressure devices and some patient-facing material. And next slide, please. And this is just where I want to end my presentation. I want us to take a moment, look at our practice, and pick one call of action. I know we are very stressful, particularly in community pharmacies, because we have additional responsibilities that we are taking on and working toward reducing the healthcare burden. And you don't have to start with everything at once. Just pick one that resonates with your practice more. Would it be that you will encourage your patients to monitor their blood pressure, or people who are at high risk inquire about their smoking status at the prescription drop-off counter, and if they say yes, provide them some more support? Would it be that you will upgrade yourself, or you would engage in continuous professional development? Call of action for me is to advocate the role of pharmacists in hypertension management and supporting the additional prescribing authorities for pharmacists, as well as the remuneration. With that, I will end my discussion. If you have any question, we're here to answer.
I'd like to thank the speakers so much for the excellent presentations and really the way forward for population prevention and control of hypertension in Canada by really engaging this vast network of pharmacies and pharmacists across the country. We do have just a couple of minutes for questions. One question came, just the observation that they did participate in 2018 in New Brunswick. But how does the audience participate? We probably have lots of pharmacists and pharmacies on this call that want to participate in May Measurement Month. How do we do this, Stephanie and Tiffany?
It's coming. So we are in the process of developing a website that will facilitate pharmacies from across the country to join in this initiative. We're hoping to have everything kind of up and running for early 2025. Tiffany is also working on some other strategies. I will let her comment on those.
Yes, I'll just say we've applied for research funding. We're really hoping to get that funding so that we can do this in a more substantial way moving into 2025. And I guess connect with Ross and Stephanie. They're your go-to people. Ross is the lead for May Measurement Month in Canada, and Stephanie's the coordinator. So they would definitely be the individuals to connect with. And we'll work with you. We'll work with any pharmacies across the country that want to take part, recognizing, of course, that there may be some training that you need to complete. As well as some upfront costs. Hopefully we get the research funding so we can reduce some of the costs on pharmacies, because we do know that, there is an expense associated with some of these activities. So yeah, I'll leave it at that. I don't know, Ross, if you have anything else to add there.
No, I think you've said it all.
Ross, do you or does Hypertension Canada have the capacity for the people on this call to just contact to express their interest in either partaking in May Measurement Month or in advocacy for a greater role for pharmacists? I think that's a team approach we're going to need.
Absolutely. We need all hands on deck for that. So I'm not sure the best way to do that. I'm happy to share my email address for those of you that are interested. I just realized that the chat doesn't go to everyone though. Maybe in the Q&A, I can try to do that somewhere. Yeah. If anyone wants to, it's rtsuyuki@ualberta.ca, or you can contact us through Hypertension Canada, hypertension.ca.
There are some other questions, but we're at 11, and Anna, I sense that means a hard stop for us.
If people are willing to stick around, we can answer a few more questions.
There was a question about screening in youth, and that's a very complex question. But if anyone wishes to take it on, age 10 to 17, screening blood pressures in pharmacies.
Yeah, it is a complicated one and yet super important. We have a group that's we're putting together to talk about pediatric and adolescent uh, screening. We're not, to be honest, we're not exactly sure what the target is. And some of the measurement issues, but it's been brought up that, well, why don't we know that? And we need to do some research in this area. So we've had a few people come forward that are interested in this and have some expertise. So we're going to try to coordinate that. And you should be able to see that in the guidelines that will be coming out next year, not the primary care guidelines, but the comprehensive guidelines that we will be working on. So it's a very good question. We don't yet have an answer.
Okay. I believe most of the questions have been answered by Ross by typing live. And so thank you so much, Ross. We are a little over time. There was a comment on CKD screening, but I think we're going to leave this at hypertension unless Ross or one of the other speakers wish to talk more broadly about NCD screening, such as kidney disease. I think it's wide open for pharmacists' role in non-communicable disease screening and management. And so I would say, sure, but we're talking about hypertension here, but other diseases certainly would be open.
Dr. Campbell, if I could just for a moment say one other quick thing, mention one thing. Folks, Hypertension Canada, you're going to see some infographics potentially posted on social media asking you to take part in a survey. As Ross mentioned, Hypertension Canada is going to be, ramping up their advocacy efforts in this area. And one of the initiatives is to find out just how many pharmacists and pharmacies are interested in taking part in a hypertension screening program. So what I would say to you is when you see that infographic, when you see the poster shared on social media, when you see it come out through your email, through your pharmacy associations, please take a moment to complete the survey. Even if you're not interested in taking part in hypertension screening, we want to hear that as well. Okay, so I just want to put a plug in for getting you to complete that survey. I think it's critical. It's central to any advocacy efforts moving forward.
Thank you so much. I'll make just one more comment. We mentioned diabetes and hypertension. I think it's really important that people recognize that hypertension is the major driver for premature death in people with diabetes. In the old days, when it was analyzed at 140/90 as a threshold, 40% of deaths in diabetes were attributed to that blood pressure. If it was reanalyzed at 130/80, it would be way over 50% of deaths. And so the major driver of poor outcomes in people with diabetes is their blood pressure. So got to do a lot better there. I thank the speakers very much, Ross, Stephanie, Sadaf, and Tiffany. Thank you so much, Anna, and Hypertension Canada for your support of this session. And we'll say goodbye now. Thank you.
Thank you,
Thanks for
everyone.
chairing too, Norm. Thanks.